My name's Dr. Lauri Chitti. I'm a staff gastroenterologist here at Flinders Medical Centre. Always begin the examination by greeting the patient. Ensure the patient is lying flat with his head supported by one pillow and his arms by his side. Expose the abdomen from the nipples down to the pubic symphysis. Now we move to the abdomen, and this is where inspection is important. Are there any scars? Is the abdomen distended? Are there visible pulsations or skin lesions such as striae? Now we move to light palpation in each area, asking the patient if there is any tenderness. Next, we proceed with deeper palpation and we watch the patient's face for any discomfort. Notice that the movement of the hand is at the metacarpophalangeal joints. Now we're feeling for the liver. The examining hand is parallel to the right costal margin, and we ask the patient to breathe in and out of his mouth. The lateral aspect of the forefinger feels for the liver edge. If it is felt, we ask ourselves, is it hard? Is it pulsatile? If palpable, we need to check the liver span. We percuss down the right mid-clavicular line till we reach an area of dullness, and then the span is measured. The normal liver size is less than 12 centimetres. Next, we feel for the spleen. The spleen enlarges inferiorly and medially, therefore we commence palpation medially below the umbilicus. A bimanual approach should always be employed, with the left hand over the lower ribs. The spleen generally is palpable if it is about 1.5 times the normal size. Now we go to percussion, and here we're trying to demonstrate ascites. If percussion is resonant, that is air, and if it is dull, then it indicates fluid is probable. We start at the midline and percuss to the left flank. Then we ask our patient to roll towards us. We need to wait 20 to 30 seconds for the fluid to shift, and therefore we check for bone marrow biopsy site at the back. And if the spleen is not felt initially, we check again using a bimanual approach. Now we try to remember our spot and check if that point of dullness has shifted, indicative of ascites. With our right hand behind the patient, we now ballot the left kidney. And now with the left hand under the patient, we ballot the right kidney. We now move on to auscultation. And it's important to determine whether bowel sounds are present. We might also be listening for friction rub, and also determine whether any renal bruits are audible.